Hello, my name is Lauren Rosa. I am a fourth-year pharmacy student from the University of Arizona, and today I'm going to tell you a little bit about the new antivenom that is coming out for rattlesnake bites called AnaVIP. So as most of you know, rattlesnakes come in a variety of sizes and colors and can be found across most of the United States. They are classified as pit vipers with 36 known species and 65 subspecies. Now experts estimate there are approximately 5,000 to 8,000 rattlesnake bites in the U.S. annually, with over 200 of those occurring in Arizona. And the study we will actually go over in just a little bit collected their data across the southern part of the U.S., ranging from California all the way to Florida. All right, before we dive into AnaVIP, I did find some interesting facts about rattlesnake bites, which again, most of you may already know, but some of these are new to me, such as rattlesnakes actually have a continuing reflex reaction, which can lead to a bite even after their death. And of course, if someone has an allergic reaction to a bite, this can definitely be fatal, so they need to seek treatment immediately. Snakes do tend to avoid people and usually only attack if they feel threatened or surprised. It's also not recommended to use ice or a tourniquet on bites, as these can actually lead to further tissue damage. And nowadays, treatments for a rattlesnake bite can actually exceed $100,000. What defines a rattlesnake bite? Well, first off, there will be some obvious local injury and tissue damage, which includes erythema, edema, 2 or even 1 puncture wound, and sometimes blebs. The reason for this tissue damage is due to the enzymes found in the rattlesnake's venom, which can directly affect blood vessels, cause skeletal muscle damage, and prominent inflammatory responses near the site. Then we have the coagulopathy, which is more seen in the labs with a marked decrease in hemoglobin, platelets, fibrinogen, and an increase in the PT and INR. And lastly, there can also be systemic signs that include hypotension and tachycardia. To the moment you all have been waiting for, what is AnaVIP? Now, in the patient insert, this is technically the definition of AnaVIP, but simply it is a horse-derived antivenom indicated for the management of adult and pediatric patients with North American rattlesnake envenomation. So, AnaVIP is made by collecting venom from rattlesnakes and injecting a very small amount into the mammal of choice, in this case being a horse. And then this is done multiple times in order for the horse to develop the adequate number of antibodies needed. And then blood is drawn from the horse, and this blood is then put through a process where it is purified and made into the antivenom. I just wanted to go back in history here for a little bit and go over some of the past antivenoms and the current antivenom used, along with the anatomy of the antibody itself. So on the left we have the full antibody, including the Fab region and the Fab and the FC portion. All of this, back in the 1950s, this is what was used to make an antivenom. So they would use this whole antibody, and it was called Wyeth. And unfortunately, this led to multiple allergic reactions and adverse drug reactions, so they ended up making a newer antivenom, which is the antivenom we use now, called Crofab. And what Crofab is it's actually the monovalent part, so the Fab region, just one side, the right side there, is Crofab. And so doing this helped decrease those allergic reactions as well as multiple drug reactions to this antivenom. Now, AnaVIP, on the other hand, is actually made from the Fab2 region, so including both the Fab regions together in the square there. So it's going to be a slightly bigger product, still minute, but just wanted to clarify the differences there on the parts of the antibody that are being used to make this antivenom. So I made this table here to compare CroFab to AnaVIP, and as you can see, there are many differences here. First, we'll start off with CroFab being sheep-derived, whereas AnaVIP is horse or equine-derived. Another big difference is the elimination half-life. So CroFab's about 15 hours, whereas AnaVIP is up to about 100 hours, so that's a very big difference. The number of snake species used to create these antivenoms I thought was very interesting. CroFab was used from 4 different rattlesnake species in the United States, but AnaVIP only used 2, and they were actually from Latin America, so they were not indigenous to the United States. And next big difference is the treatment dosing. So CroFab can range from 4 to 6 vials, whereas AnaVIP you're going to need 10 vials. And then if needed, maintenance dosing, CroFab 2 vials, AnaVIP 4. And so the biggest difference, or the reason for these 10 vials, is because there is a strength difference between CroFab and AnaVIP, and it is about a 1-to-2 ratio. So every 1 vial of CroFab would equal 2 vials of AnaVIP. And moving on to the pricing per vial, right now CroFab is running at about $3,000 a vial. I tried to get a pricing estimate from Rare Disease Therapeutics on the price for AnaVIP, and unfortunately they could not give me that. They did say that the price will be announced in October, but they did add that AnaVIP, when started with 10 vials, will be less expensive than CroFab in any scenario. So take that as you will, could be very reassuring, but we'll have to wait till October to actually find out how much that'll be. And then lastly, we have the most common adverse drug reactions from each, with the main one being delayed coagulopathy. And we will go over this in the study that we're going to talk about next, but that's been a long ongoing issue with CroFab. Unfortunately, with the half-life being so short, it doesn't last quite as long as the venom itself does last in the body, so this can lead to delayed coagulopathy, whereas in the study, AnaVIP showed that this was not the case. So, just like any new drug that hits the market, post-marketing was done for CroFab, and essentially this is a phase 4 clinical trial. And the most concerning thing that they found was this delayed or recurrent coagulopathy or thrombocytopenia. And they define this as platelets less than 150,000 or fibrinogen less than 150. And studies have shown that and it's a big range, but 8 to 53% of patients will experience this even if they are treated with CroFab. So now we have this drug that addresses this exact issue. With a prolonged half-life, the novel antivenom has almost 10 times as long of a half-life as the CroFab itself. Lucky for us, there was a study done comparing CroFab to AnaVIP, and this was published in Clinical Toxicology in 2015. And in this article, they do state that there have been serious, even fatal bleeding complications associated with this delayed coagulopathy, requiring frequent follow-ups, additional intervention or hospitalization, which are often necessary. So they also mentioned that the Fab2 region of the immunoglobulin derivatives have longer plasma half-lives compared to just the Fab regions. So they conducted this study after AnaVIP was made and approved, and so we'll kind of go into the methods, results, what does it mean for, in place of therapy. The study compared 3 treatment groups. First group receiving AnaVIP treatment dosing, AnaVIP maintenance dosing. Second group just getting AnaVIP treatment dosing, but a placebo as their maintenance dose. And third group being treated with Crofab and maintenance dose of Crofab. And they did this across 18 clinical sites with a total number of patients being 114. And so 39 patients were in the first group, 38 patients were in the second group, and 37 patients were in the last group. And so what they did is they initiated either 10 vials of AnaVIP or 5 vials of Crofab for the initial treatment. And again, this is because Crofab and AnaVIP is a 1-to-2 ratio. So they just doubled the AnaVIP to 10, halved it, 5 vials of Crofab. And they did this over 1 hour and re-administered these more as an as-needed basis, so every 2 hours until initial control was achieved. And they define initial control as 1, swelling not progressing more than 1 inch per hour, 2, platelet count, serum fibrinogen level, PT and PTT were either normal or returning toward normal, which there's no clear definition on that. And then if the groups did receive the maintenance dosing, they either received 4 vials of AnaVIP or 2 vials of Crofab. And this would be administered every 6 hours for 3 doses. And this could continue at the physician's discretion again. And vitals were also measured, so vitals, measurements, and labs were done every 2 hours, and this consisted of swelling measurements, the CBC, PT, INR, fibrinogen, and then the venom and antivenom levels. They also did this on days 5, 8, and 15 during the follow-up visits. And then on day 22, they just did a follow-up phone call. So the primary efficacy endpoint was defined as coagulopathy between the end of the maintenance dosing and day 8. And again, this is defined as platelets being less than 150,000, fibrinogen being less than 150, or the use of antivenom to treat coagulopathy between the end of the maintenance dose and day 5. And so the results are shown here, and it is pretty clear that group 3, which is the group that was treated with Crofab, has a much higher percentage than both groups 1 and 2. So with group 3 having 11 patients, or 29.7%, having the delayed coagulopathy, compared to group 1, which was around 10.3%, and group 2, which was 5.3%. So there is a clear reduction, but it still does not eliminate it completely. So we got to ask ourselves, is it really worth it? And so if you actually calculate out the number of patients needed to treat, and let's say we use the average of the first and the second treatment groups, which would be, around 7%, the number needed to treat would be 5. And so what this means is that for every 5 patients treated with AnaVIP, 1 will receive benefit, meaning no late coagulopathy, as compared to if they'd received Crofab instead. Now, let's not all jump on the AnaVIP bandwagon. It does still have a lot to prove, and there are some limitations to this one study that was done. They had a limited number of patients in each group. You got to think 30 patients, 40, that's not too much to compare to. And in addition to that, the first group, the AnaVIP group, had more children in it than all the other groups. It actually had 12 children in it, less than 10, whereas group 2 only had 5, group 3 only had 1. Just to kind of put that in perspective, last year in Arizona, only 13% of the total rattlesnake bites were children less than 12. So with them having 12 out of their 39 patients being children, this could possibly have a co-founding effect. And they do mention this in their limitations, but don't address exactly what it means. And then you always want to keep in mind that this study was, of course, funded by Rare Disease Therapeutics. So the results are going to be something kind of like what they wanted to see, and you just got to remember that. In conclusion, the study states that the management of rattlesnake envenomation with AnaVIP, with or without maintenance dosing, reduced the risk of subacute coagulopathy and bleeding following treatment. And they then go on to say that the need for repeated blood testing after treatment could be reduced, in addition to maintenance dosing not even being required at all. So we just need to ask ourselves, with the limitations of this study, is there enough pertinent information to convince us to replace CroFab with AnaVIP? And can we use this study to justify treatment changes for these patients? Following this slide are some questions I would like you to answer that really drive the main points of this talk. And of course, if you have any further questions, please don't hesitate to email me, with my email being rosa@pharmacy.arizona.edu. And thank you very much for listening to me talk about AnaVIP. 17 minutes.